It's a real pleasure being with you today, and a great honor. I have one main goal today, and that's to share with you some observations from what happens when you go the route of formally legalizing euthanasia, as we've done in the Netherlands. And there are two effects from that, which I think are important warnings, in a sense, to the Irish context. The first one is that when one legalizes euthanasia, it is unavoidable that you get incremental extension of the kind of conditions for which one thinks it's a good idea to use that category. So the category grows unavoidably, and the Dutch data indicates this. So that's a point I'm going to be arguing with my slides. The second one is that where in the Netherlands we had thought by formalizing euthanasia, pinning down legal double checks, etc., trying to build in safeguards, that we would push back backdoor euthanasia. That means the gray zone of life-ending treatment by physicians, that we would make it all formal, out in the open, get people willing to, lay it out there. And exactly the opposite has happened. And the data doesn't lie on this point. There's a lot more backdoor euthanasia taking place today than there was on the day that we legalized. Not a little bit, a lot more. And this is going to be something that I'm going to try and argue. Okay, what drives, just at a societal level, the move towards wanting to somehow deal differently with end-of-life situations is actually a shift in how we frame the concept compassion. If you look at the Latin word that is behind compatio, compassion, com means together with, patio, pator, passus sum, that means to have intensity and suffer. That is something together with, to enter into somebody's suffering. A good translation in English would be to endure with, in a sense. And the shift has been away from enduring with or entering into somebody's suffering to trying to terminate that suffering, and in many cases to remove the sufferer. And this is something which there's a challenge for me here. It's incredibly hard to see somebody else suffering. It's incredibly hard to see somebody else suffering. And if we're not willing to endure with somebody in their suffering, the risk is there that it becomes, let me help you out of my suffering, rather than let me help you in your suffering. That's the challenge. And this is a deeply human sort of a sentiment which can easily happen. It's difficult to watch suffering. And so the risk for nursing personnel, for physicians, for next of kin, is to just want it to stop, and that's a tricky emotion. Most euthanasia requests have an existential or psychological motivation. That means fear of impending pain, not the pain itself, typically, but fear that it's going to get worse, which is very much a psychological playing field. Loneliness. Not having enough people to live for, feeling a burden to your fellow man, to family members, etc. These are the motives which are cited most. And so, far from being a playing field where we're simply talking about how you deal with physical pain, euthanasia is a playing field of talking how you deal with meaning, existence for human beings. And this asks, indeed, that we enter into people's suffering, that we stand beside them, not that we remove them. There's a lot of cultural pressure in this direction, lots of movies. And in a sense, it is our love for liberty, which is our Achilles heel. If you think of the three values that came out of the French Revolution, liberté, fraternité, égalité. Liberty, that one's fully intact. Brotherhood, fraternity, well, how much solidarity is there left in our culture? Are we willing to, take a salary cut so that others can have more? Solidarity is waning in our culture. And equality, we have a bigger poverty gap, the distance between the rich and the poor, is greater than ever before in history. We're not making good on our commitment to equality. And so we run the risk of devaluing certain kinds of life as being less equal than others. Now, I'm going to start out here with some graphs, because the data is compelling when you see it visually. This is data from the World Health Organization database 2011. That's 1970. That's 2010. And these are the mortality statistics. That means the number of people per 100,000 men dying in the Netherlands compared to the EU median. And that's of the 15 wealthiest nations in the EU, the countries that the Netherlands should be comparing itself with. That's that greeny yellow line there. The red line is the Dutch data. And I just put Italy and France in there so that you have some sort of, alternative to see how the comparison goes. This is the mortality for men. In 1970, the Netherlands was doing really well. Low mortality rate means people were living longer. We were in a good position because we have a very good GP system. Everybody has their own physician, etc. Then you see in the mid-80s, 1984, 85, 86, something radical starts to change in the Netherlands. And, it's undeniable if you look at the way the data here flatlines and meanders into the stats of the rest of Europe, while the rest are all parallel facing downwards. Medical systems are doing better all over Europe. Between 1970 and 2010, there's been a great improvement of longevity. And then by the time you hit 1991, the Dutch statistic comes out above the EU 15 and continues to actually get worse. And if we look at the female statistics, you have the same picture. Here you see that France has a very similar mortality rate for women in 1970 as does the Netherlands. France parallels the European average development. The Netherlands really meanders way above what is happening in the rest of Europe. I think this also indicates that assisted suicide and euthanasia policies are actually women unfriendly, in the sense that women are more likely to make use of them than men. This is something that's indicated. 70% of the assisted suicides in Oregon have been female, which also, it really raises the question, where's the power play in all of this? Okay, a short history. Both euthanasia and assisted suicide have been widely practiced in the Netherlands since, let's say, the mid-1970s. Now, it's small startings and growing, but the first court case was 1973, Gertrude Postma. She killed her mother with a morphine overdose and only got a slap on the wrist. 1 week suspended sentence. And, importantly, the court formulated some criteria that it would have wanted to have seen met in the way she behaved. Now, this became a template. And here you see that developments in the court cases, so laws not applied in the first instance, is the doorway to euthanasia. This is the way it goes in a culture. You start when the laws stop being fully applied. And this is a warning. Any society that sees that happening knows that the end of the line will be fairly widespread euthanasia and assisted suicide in their culture, without a doubt. In 1984, this increased practice led to a formalized kind of protocol, a deal between the Dutch Royal Medical Association, the KNMG, and the justice system in the Netherlands. If you follow these criteria, then we'll hold off as a legal justice system. So this is not a formal legalization. There's no law that says it's legal to kill people, but de facto, it's sort of legal. And that's why you see in the mortality statistics that 1984, that's that hinge. That's the moment when everything flatlines and when the Dutch statistics go haywire. When the medical profession is on board and the justice system says we accept. That's when the real change comes. The formal legalization, which happened in 2001 in the Netherlands, really was simply putting a rubber stamp on a situation that had become commonplace. And so you don't see that much change in the formal euthanasias. But here's the thing that I'm trying to get across today. You do see a big sort of acceleration of attitudes and of backdoor euthanasias after 2001. And this is an ongoing process. These are the 5 due procedure criteria in the Netherlands. You can look them up on the internet. Basically, there needs to be unbearable suffering, and there needs to be informed consent. And what was first the intent, i.e. physical suffering, has been increased to include psychological suffering, and has been increased, once again, to include existential suffering. You know that being tired of life is couched as unbearable suffering in the Netherlands. It qualifies you for euthanasia. Levensmoe. How vague is that? I mean, whose definition are we using here? You've had a change in the way the label euthanasia is used. On the one hand, things that are not active killing, I think correctly, are not used. One had a very muddy sort of discussion about euthanasia. I don't think that there's a treatment imperative, and so to say we're going to stop a treatment is not to kill somebody actively, and indeed should be removed. But what we've gotten is in the formulations around terminal sedation, there's something tricky. There's a legitimate place for sedation in palliative care, but it can become code language for active killing, and this is a very, very tricky thing. There's a challenge for all of us. And the reason why I'm highlighting that element and what I'm going to be telling you further now is that actually in this realm, the situation in Ireland on the ground is already much further along than one might actually want. The grey zone in this sense is a tricky one, and it's a tricky one here also. And it will become trickier in the degree to which the attitudes of the medical profession slide. In September 1991, we had the first formalized Dutch government study. About 3,500 euthanasias were done. And the interesting figure there is that 1,040 were administered without patient's consent. And if you zoom into that, you find out that about 440 of those people were incompetent. That means that they were so sick that they couldn't be giving informed consent anymore. But the rest, the other 590 or something like that, were actually capable of giving an opinion, but weren't asked. And we've just come to accept this as the way it goes. You know, that's chilling. There's something incredibly wrong with this picture. And what confounds me is that we're so nuanced and nice about it in the Netherlands. There's something deeply wrong with killing people when they haven't asked you to kill them, you know. I mean, I think there's something wrong with killing people in the first place, but this is so explicit, so overt. Anyway, in the Netherlands, we've done rigorous data collection, and so the rest of you get to see it. And you should go and take a good look at the Dutch data, because it's a chilling story, and it's one that should warn you to not go this route. Absolute figures. The number of euthanasia cases in the Netherlands in 2001, when we legalized, was 3,500. That actually dropped to 2,300 in 2005. What was happening there? There's a lot of people looking over your shoulder when you have to go via the legal procedure, second opinion, physicians, etc. It got lots more complicated. There was more paperwork. Physicians opted for the backdoor option. Now, everybody was saying, look, see, no slippery slope. We've had a drop in the euthanasia figures. And between 2005 and 2008, it stayed stable. But since 2009, now that everybody's gotten nice and comfortable with it, we have an increase of 15% year by year. That's an exponential curve, people. That's 15% of an ever-increasing number. So that's a curve that is spiraling, skyrocketing. The most recent figures are approximately 5,500 people in 2014. We have 140,000 deaths total in the Netherlands. That's the total mortality in our population. 5,500 of those are formal euthanasias. That's a lot of death, people. People being killed and growing, you know, increasing radically. Nobody can say that this thing is not a steam engine running out of control. It is gaining momentum by the day. And it's having effects on the psyche of a culture, which are really not pleasant. And here I become personal. This man sitting in the wheelchair there, that's my grandfather. This is my extended family. And his name is Henk Reitsma, as is mine. I'm his namesake. In 1996, you know, if you think back to the graphs I showed you, in 1996, that was the moment when the Dutch mortality stats finally came out above the EU median. So actually, the major change had already taken place between 1984 and 96 in those 10 years. My grandfather was in an old people's home. He had a partially paralyzed left arm and left leg because he'd had a stroke. He was mentally all there, you know, still beating us in card games, etc. A man who loved life, was active on the representative committee of the old people's home he lived in. My grandmother lived one street block away and visited him every day. My cousins and I, we visited him often. He was the real patriarch of the clan. Then he got diagnosed with non-Hodgkin's cancer. The biopsy came back from the hospital, you know, affirming that it indeed was non-Hodgkin's. A week later, he was dead. What happened? I'd visited him on the Monday and wondered, why is he so sort of sedated, so, you know, non-communicative? On Thursday of that week, an aunt of mine was visiting, and she gave him some water, and one of the nurses said, no, don't do that. You're prolonging his process of dying. And she said, what do you mean? He's thirsty, which he was. And that was the moment that the family discovered that the physician was treating to terminate morphine overdose, withholding hydration. And this was considered palliation. He had asked for some pain treatment for his thrombotic leg, and the physician had told the nurses, you know, up the dosage a bit and withhold moisture because this guy's only going to have a painful, you know, he has non-Hodgkin's, he's 80. It'll probably be 3 years of suffering. Let's spare him the effort. Now, obviously, this is not what the Dutch law wants. Everybody is shocked when they hear the story. But the truth is that this had become the normalized mode of thinking for that physician. And if you look at the news reports over the last 20 years in the Netherlands, so many more. Roert van Putten ziekenhuis, Dr. Tromp van Tuitjenshorn, etc., etc. I can go on with endless examples. There's way too much of this in the Netherlands. This is what happens when you say that it's normal for a physician to kill his patients. An unavoidable consequence, as far as I'm concerned. There's no way to stop this kind of incremental change in mindset once you say it's okay to kill patients. And one more thing, the knock-forward consequences are unbelievable. My grandmother, a few years later, when she had to go to an old people's home, she chose to go 200 kilometers further away. Now in the Netherlands, that's you know, eternal distance. We're a postage stamp of a country. She'd lived in a 5-kilometer radius all her life. Had a church community, had a really deeply embedded community where people loved her and cared for her. She went to a place where she knew almost nobody to be safe. To a very conservative Christian old people's home where she thought, at least they won't, kill me prematurely. My heart was bleeding for my grandma. That was a sad footnote to this event, that she had to go someplace for that last phase where there wasn't as much warmth as there would have been otherwise. And we should not want to be in a culture where that happens. That simply is not the direction we want to go. Now, continuous deep sedation. This is a sort of protocolized way of dealing with people who have the worst kind of suffering at the end of life. And it can be done well if it is really restricted to the last 48 hours, to the terminal phase. Physicians are very bad at predicting when somebody is going to die if they have to do it weeks, months, years ahead of time. We all know stories about physicians getting it wrong. But in the last, really, really last phase, when somebody's organs are slowly closing down, etc., it can be something that is necessary to do, to sedate somebody down quite a ways, and maybe even fully. But to protocolize continuous deep sedation as the normal way of dealing with people in their last phase of life. This is increasingly the way it is going in the Western world, and the Netherlands is leading the charge. It's dangerous. It's dangerous because the moment of initiation is all defining. If you do it too early, you end up killing somebody. You might be robbing them of years of their life. If you put somebody into a comatose state and don't hydrate them, they die. And so we need to be very careful about the way that we couch, formulate, and think about the protocolized use of total sedation in the terminal phase. And I would like us to stop using the combined continuous deep phraseology. I'd like us to talk about treating symptoms. We can sedate to treat symptoms. You see, the drugs that are used for this kind of sedation, you can titrate down to an exact level so that you remove, for example, respiratory angst or a sense of physical pain. You can sedate somebody down not to full unconsciousness, but just to the level when their symptoms are treated. And this is, I think, a much more rational way to go about using sedatives. You can go for partial sedation. You can go for intermittent sedation. That means that you plan to bring somebody to the surface from time to time to check whether they're okay. Or you can say, we're just going to continue deep until death. And that's the direction we've gone. And I think that we've not been sufficiently careful. Because in this playing field, continuous deep sedation until death, there's a lot of backdoor euthanasia in the Netherlands taking place. And I'm fairly convicted of this. I've been spending a lot of time looking at the data over the last 10 years, and I can draw no other conclusion. So here we go. Just as I move towards close. The mantra is palliative sedation is not euthanasia. It does not intend to shorten life. The intent is pain relief. That's the way it should be. But the let's say uncontrolled moment of initiation is very tricky. The trend has been to do less hydration. In 2005, there was still 34% of terminal sedations where hydration was used. In 2010, there was 21%. In 2015, that's probably going to be 15%. I'm just going to slip by this. All the studies done on life-shortening effects have been done in the hyper-controlled environment. And it's the uncontrolled sort of home situation where 90% of terminal sedations in the Netherlands happen in the home environment where a GP calls the shots, a nurse applies it, etc. And it's a very tricky environment. It's one where, you don't have any double checking. You don't need to even have the consent of the patient, because if it's really about pain treatment, it's good medicine to treat the pain properly. But if it's a gray space in which you can terminate somebody's life, then it's a very, very dangerous thing. In France, we've had this debate about legalizing terminal sedation over the last months. And looking at the debate, it's clear that in the minds of some people in society, this is a way to sidestep the whole euthanasia debate and to get something that maybe makes space to not need to talk about euthanasia, because you're actually having a backdoor euthanasia situation. Now, the figures. Continuous deep sedation in the Netherlands. 2001, when we legalized, 5.6% of all deaths happened with continuous deep sedation. In 2005, there was 8.2%. That's a massive increase. We're talking about thousands and thousands more cases of terminal deep sedation being used. That's that phase in which you had the shift from formalized euthanasias to backdoor euthanasias via terminal sedation. In 2010, it was up to 12.5%. In 2013, the most recent data, it's up to 16%. I mean, this is a linear curve. At this pace, it's only going to take a few years, and everybody who dies is going to be dying under the circumstance of continuous deep sedation. 16%, that's 40,000 deaths in the Netherlands are happening with the use. There's no way that medical conditions changed so much in the few years that this increase was necessary. It's a change of mind, which is behind these figures. And one sees the drug of choice, midazolam, which is used for that, has increased from 12,000 dosages to 40,000, which is three times as much in 10 years. So that's a massive 300% increase in 10 years. It's really massively going in that direction. And in the Netherlands, our protocols are much more, let's say, liberal. The LCP, the Liverpool Care Pathway, which already had a lot of opposition in the UK because people sensed that it might be being misused. In the Netherlands, our protocols allow for twice as much of the drugs involved as in the UK. And we have no outcry against our protocols. And that space is not only available in the protocol, it's actually being used. The mean starting dose in this study, 2010, I think it was 2010. In any case, the mean starting dose in the Netherlands in this study indicated that it was 31 milligrams every 24 hours, which is already above the maximum dosage that the UK protocol would allow for. We see the oncology, the Cancer Society in the Netherlands saying at least 10% of palliative sedation or terminal sedation cases are being initiated too early. And this is data that they are collecting from their constituents. 10% of 40,000 deaths, 4,000 deaths. That's an almost doubling of our euthanasia stats, and I think this is very conservative data. You know, they wouldn't be coming out willing to say this if it wasn't a very, very strong indicative case. Agnes van der Heijden, who was involved with the government studies, she already in her study, along with some other colleagues, 2007, indicated that there was this shift from euthanasia to backdoor euthanasia via terminal sedation. Here I'm quoting somebody who I never quote otherwise. This is a woman who was the leader of the Dutch pro-euthanasia movement, the NVVE. And she, Petra de Jong, says the following: the percentage of people dying from palliative sedation is rising disproportionately. Governments, and she quotes the government data, I call this disproportionate because it obviously is not likely that in 5 years the number of people dying for this treatment would, or qualifying for this treatment would rise so sharply, while palliative care in general has qualitatively improved so much in the meantime. It has all the signs of the fact that physicians are using palliative sedation as a backdoor for euthanasia. So we have this shifting perceptions, and if we look at the physicians, we see that by this time, a way higher percentage of physicians are willing to do euthanasia than at the moment when we legalized in 2001. We're up to 86%. 86% of all Dutch doctors, when asked on a questionnaire, say that in principle they would be willing to do it. 33% would be willing to euthanize somebody for psychiatric reasons. That's something that was totally outside of the scope of our law when we formulated in 2001. So quickly the attitudes change. 27% of physicians would be willing to euthanize somebody who felt they were suffering from life. That means tired of life, that very vague category. 27% of physicians in the Netherlands might be willing to go that way. You know, this really is incremental extension. There's no two ways about it. 70% of physicians feel pressure to do euthanasia from patients and their next of kin. And this is one of the other side effects. Everybody in the Netherlands by this time thinks it's their right to demand that the doctor kill them. It's horrible for the physicians. The other day, I was at a concert and I bumped into a young physician who had been a visitor at our center some years ago, a lovely young lady who has her own practice. And knowing that I was going to be talking about euthanasia, I asked her, so, you know, are you confronted with this in your practice? Right there and then, in the foyer of the concert hall, she burst out in tears. She wept bitterly. And yeah, I felt really bad for having put her on the spot in such a public place. But she was thankful that I was talking about it. She said, you don't know how big the pressure is. I'm one of those few physicians who just doesn't feel comfortable killing people. And man, I get a lot of criticism from the people around me. It's difficult to be one of that 14%. She says, the only person that's encouraging is my pharmacist, the guy who's giving the drugs. He said, stick with it, you know. But other than that, the poor girl was feeling so dreadfully alone. The pressure increases massively. And all signs are there that doing euthanasia and the euthanasia requests are the biggest stressor of all stress factors in the life of Dutch physicians. You don't want to go there. People have said no slippery slope. Well, I think it's clear that there is an incremental extension, whether we like to acknowledge it or not. Half of the double-check doctors, what we call scan physicians in the Netherlands, indicate that they themselves have shifted in terms of which categories they are okaying as being okay for euthanasia. And so the whole industry is admitting and acknowledging that there's this widening of the scope. It's the unavoidable effect. Once you open the door, it gets wider and wider. Some closing remarks about dying with dignity. In the first place, dignity is intrinsic and universal, as any other definition than the statement that human beings have a universal dignity would foster racism, eugenics, etc. It would be to declare some people less dignified than others. To say, well, you know, people who are vulnerable are actually lack dignity. Somebody who has a handicap lacks dignity. Crap, you know, I cannot be strong enough. This is not the way we go. This is just not the way we deal with each other in the world. To die with dignity is to die being loved and cared for. The implicit message being, you're worthwhile, you're worth it. And so there's a task for all of us. A technique-oriented society finds it exceedingly difficult not to have a remedy. So we've got to let nature do its work, which means that we should also not be over-treating. In closing, there's a radical loss of meaning when you totally sedate somebody. You know, a sense of meaning, that's everything we have, actually. That's the bedrock of life. It's what makes human beings so special, this realm of meaning. We should be treating to try and sustain as much interaction with the realm of meaning as possible. And we should realize that when we are confronted with people who want to kill themselves, with people who are suicidal, it is reminding them of the meaning they represent, which is our core task. That's always been good care. Don't look away. It's really hard to see somebody suffering. We cringe when somebody winces. But look at this. This is one of those moments rare moments where we actually do the as yourself part of loving our fellow human beings best. When you cringe, you are enduring with, you are, being with somebody else. And when you stop to think about it, care is our birthright. It's one of the distinctives that makes us human. Each and every one of the people in this hallway were cared for a long time when they were helpless babes. A mother, a caregiver, looked after you when you needed care because you were fragile. The goats in the field outside my home are up within the hour, prancing around. They focus their eyes, they bump against their mothers, demanding their milk. Human beings need to be cared for a long time. If we stop being willing to care for the vulnerable, we sell our birthright. Don't go there. Thank you.